Hello, and thank you for attending the Academy of Medicine of Cincinnati's 2026 Pre-Hospital Care Clinical Practice Guidelines training. My name is Dr. Tom Charlton. I, along with my co-chair, Captain Kevin Richards, would like to thank the entire protocol committee for their hard work over the last year at producing these protocols. The protocol committee has spent a significant amount of time drafting this document. It has been rebuilt from the ground up, ensuring compatibility for the future. Extra attention was paid to ensuring every hyperlink worked. A new proofreading process was implemented, ensuring that when we publish a document, it's the final draft. A series of hyperlinks were added to the end of the document, linking to the online-only appendices. The Regional Site Capabilities Survey was added as Appendix V. Many of the flowcharts within the document were redone, again ensuring future compatibility. Lastly, to align with the introduction of the LifePak 35 and its ability to perform 15-lead EKGs, the term 12-lead EKG was replaced with diagnostic EKG. We have several new protocols to discuss. In an effort to better prioritize immediate actions in critical patients, SB 212, crashing patient, was added. Based on other success around the country, we added M420, opiate withdrawal, so we can treat patients immediately, protecting them from another overdose and connecting them with long-term treatment. S503, superficial tranexamic acid, was added so we can use TXA on superficial wounds such as skin tears. In a major development, T700, blood and blood product administration, was added. This capability enables departments around the region to begin carrying blood and blood products for EMS initiation. Our last new protocol is T715, ventilator sedation. This permits sedation following intubation, facilitating safer transports for our more rural agencies. There are numerous updated protocols as well. Rather than reading off each protocol, I'll just get into the education on them. Several appendices were updated as well. In an effort to make the obstetrics protocols easier to navigate, the previous two protocols were expanded into 5: 0800, imminent delivery; 0801, delivery complications; 0802, pregnancy complications and postpartum care; 0803, pregnancy trauma guidelines; and finally, 0804, pregnancy cardiac arrest. No new information was added. The protocols were simply broken into smaller pieces. Let's start with the new protocols for 2026. SB 212, crashing patient, was developed off of several other similar protocols around the country. Other protocols have shown improvement in outcomes following initiation of this prioritization. This protocol is intended to emphasize certain assessments and interventions that are high yield for the actively crashing patient. Some of these actions ideally are accomplished prior to movement and/or transportation. The protocol emphasizes airway interventions such as CPAP, bronchodilators, or bag valve mask ventilation. It also recommends early and frequent vital sign monitoring. Early IV or IO access is also emphasized, allowing us to treat shock before moving the critical patient. When dealing with a crashing patient, it is imperative that the patient is kept on monitor until they are moved to the hospital bed. This protocol means that when we encounter a critical medically ill patient, it is sometimes better to stabilize in place quickly and then move them out to the truck. Our new opioid withdrawal protocol, M420, has enough training requirements that we are breaking this off of our normal protocol video. Agencies choosing to adopt this protocol will need to refer to that separate training. While we have been using intravenous TXA for some time, there are other indications for its use. S503 expands its use to superficial bleeding, such as superficial skin tears, superficial penile lacerations, or epistaxis. If the patient has one of these wounds and direct pressure has not stopped the bleeding within 10 minutes, or where direct pressure is not ideal, soak a gauze pad in an undiluted ampule of TXA and hold in place with pressure over the wound. This protocol should not be used on deep or penetrating injuries, bleeding from dialysis fistulas, or anyone in whom IV TXA has already been administered. T700 blood and blood product administration also requires separate training from the overall protocol training. Each agency may have different procedures and policies on the administrative aspects of blood product administration. Therefore, each agency is responsible for training their staff. If your agency provides mutual aid to a blood product carrying agency, it is important to review this protocol and that agency's associated training. T715, sedation after intubation, was added for next year, permitting us to treat resulting pain and anxiety following intubation. This sedation is only permitted following orotracheal intubation and not supraglottic devices. The protocol permits the use of midazolam or ketamine based on parameters on the next slide. It is important to document the patient's level of consciousness and pain levels before and every 10 minutes after administration of the medication. When handing off care to the hospital, please inform the staff of the medication used, when it was given, and how many doses were administered. In patients with a systolic blood pressure of greater than 100 and less than 150, either ketamine or the combination of an opiate plus midazolam may be given. In patients with a systolic blood pressure greater than 150 or are at risk of hypertension, such as stroke or stimulant overdose, the paramedic has the option of midazolam plus either morphine or fentanyl. In patients with a systolic blood pressure of less than 100 or are at risk of hypotension, such as trauma, sepsis, asthma, ketamine is the preferred drug. Ketamine may be used with push-dose epinephrine in this population if needed. Now for the updates. A101 spells out our pre-hospital communications. The regional EMS coordinators request that reports be formatted in the MISTR, M-I-S-T-R, format. This stands for mechanism of injury or medical complaint, injuries or illnesses, signs such as vital signs, treatment for anything provided, and resources if any are needed on presentation to the hospital. While the Academy of Medicine does not have a specific rapid sequence intubation protocol, the Academy has made adjustments to our administrative recommendations surrounding pharmacologic-assisted intubation. Additionally, Kentucky-specific language was added. The realities of our healthcare system is that sometimes patients need to move from one hospital to another quickly. In an effort to protocolize this process, A108 was renamed Use of EMS for Emergent Interfacility Transfer. The protocol now references the requirements of EMTALA, ensuring that this law is followed. Importantly, this protocol does not obligate a department providing 911 services to perform these transfers. Providers do not have to take medications or equipment that they are unfamiliar with. It is important that the crew receive written orders from a physician at the transferring facility for any treatments outside of protocol. It is extremely important that each member of the crew knows their scope of practice and does not exceed that ceiling despite an order. Lastly, this protocol spells out that during an interfacility transfer, the lead paramedic retains the primary decision-making authority, not hospital staff. A109, the Advanced EMT Protocol, was enhanced, adding in state-specific scopes of practice and approved medications. SB204, cardiac arrest, had a significant update. As pre-hospital care of cardiac arrest has improved, it has created a new phenomenon. Our CPR has gotten good enough that in some patients, some degree of consciousness may occur with the improved cerebral perfusion. These patients may exhibit extremity movement, attempt to sit up, make purposeful movements, develop a gag reflex, and may vocalize distress. Despite these findings, continue to provide CPR. At the next rhythm check, if these signs cease when CPR stops, this may be CPR-induced consciousness. If you encounter CPR-induced consciousness, paramedics may administer midazolam 2 to 5 milligrams IV or IO every 10 minutes if this consciousness interferes with CPR. In some cases, restraints may be needed. The Bradycardia protocol, C302, had a few clarifications added. Wording was added that in these patients, the heart rate typically is less than 50 if in a bradyarrhythmia. Paramedics should not delay treatment to obtain a diagnostic EKG. They also do not have to call medical control prior to initiation of medications or pacing. Pacing pads should now be placed anterior-posterior. The Academy was also made aware that some manufacturers' monitors default to demand pacing. This may mean that the monitor may not adequately pace if the software becomes confused over a ventricular beat or artifact from movement. If you encounter this and there is sudden loss of electromechanical capture, you may need to change your device to non-demand or asynchronous pacing. Speak to your department about your specific device. C305, stable narrow-complex tachycardia, was updated to reflect a weight-based approach to the initial adenosine dose. In patients who weigh less than 90 kilograms or 200 pounds, the first dose remains 6 milligrams. If ineffective, a second dose of 12 milligrams may be given. In patients who weigh over 90 kilograms or 200 pounds, the initial dose is now 12 milligrams, which may be repeated once if ineffective. A reminder to all that the modified Valsalva maneuver should be attempted before medication. C307, post-return of spontaneous circulation care, had a few updates. Goal and tidal capnography target is 35 to 45 millimeters of mercury. However, that is only after effective circulation is established. Once the patient's perfusion and ventilation are stabilizing, providers may begin titrating ventilations to this goal. A reference was also added to the new sedation after intubation procedure. In the continuing evolution of our restraint protocol, a new method of assessing levels of agitation was added. The Richmond Agitation Sedation Scale has been used elsewhere in healthcare for some time. This takes our previous observations and provides an objective score that can guide treatment. Patients with an RASS of 0 are alert and calm. Patients exhibiting restlessness, anxiousness, apprehension, but movements are not aggressive or vigorous are a +1. Patients with a RASS of +2 are now more agitated, uncooperative, may resist care, and have frequent non-purposeful movement. A patient with a RASS of +3 are pulling at equipment, may fight their environment, cannot focus, and are very agitated. When patients become combative, violent, and present an immediate danger to staff, they are scored a +4. Now that we have an objective score, we can more easily titrate our treatment to the patient. In all of these cases, if you have a smaller adult or an elderly patient, the dose may be reduced if needed. For a RASS of +2, these patients may be given midazolam 5 milligrams intramuscular. For a RASS of +3, midazolam is now 10 milligrams IM. In patients with a RASS of +4, those that are in immediate danger to staff, ketamine at 4 milligrams per kilogram ideal body weight, or as indicated in the dosing chart, may be administered. It is imperative that you document a RASS score in your report if chemically restraining a patient. M415, which deals with pre-existing medical devices, is where we turn to for any ventricular assist device concerns. A new flowchart has been added on how to care for these patients in the unresponsive VAD patient. It also includes the VAD coordinator's number to assist in management. An important point is that the flowchart only applies to adult patients. For pediatric VAD patients, please call the children's VAD team. As 504, eye injuries, had some language clarifications. It now spells out that irrigation should occur for at least 15 minutes. To couple with our new superficial TXA protocol, S508 Epistaxis was updated. If your initial medication and clamping is not successful in stopping the nosebleed, paramedics now have the option of administering intranasal atomized TXA. To do this, take the undiluted contents of the TXA vial and put it into a syringe. Attach the atomizer and instill a half milliliter into the bleeding nostril. If you're unsure on which is bleeding, it may be applied to both. Reclamp the patient following administration. Cincinnati Children's added language to P601, Pediatric VFib or VTAC arrest protocol. It now includes, quote, after resuscitation has been initiated, arrange for early transport and notify the receiving hospital, unquote. VFib and VTAC are rare in children. P605, Pediatric Stridor, had minimal changes. The inclusion criteria and differential diagnosis within the flowchart were reorganized. P619, Pediatric Brewy, adds that routine transportation is recommended of these patients, even if the child is not deemed high risk. If caregivers still want to refuse, contact medical control as they may be able to change their mind. Our existing T713 mechanical ventilator setup and management had a few changes. Some clarification was added to the name and the overall standards for use. An EMT section was broken out. This spells out that EMTs should still request ALS backup. It authorizes EMTs to remove patients from ventilators and manually bag them if the ventilator is malfunctioning or the patient is in respiratory distress. If a patient is stable on the ventilator and patient's caregiver can manage the ventilator, EMTs may begin transport with the caregiver using the patient's normal ventilator. Appendix A, chemical agent exposure, and Appendix B, transportation of the contaminated patient, are protocols none of us want to ever use. Regardless, it's important that we recognize the signs of nerve agent or organophosphate poisoning. Dr. Otten has recommended we switch to the mnemonic dumbbells. This stands for D, defecation, U, urination, M, meiosis or pinpoint pupils, B, bradycardia or bronchorrhea, E, emesis, L, lacrimation, and S, salivation. The national poison control number and the local number were added to the protocol. The reference to the now sunset Wiser application was removed. Our last protocol is Appendix E, immunizations. The core content of the protocol remains unchanged. State-specific information for Kentucky and Indiana are also unchanged. For Ohio providers, EMTs and above are now permitted, if the medical director approves and publishes a protocol, to administer any vaccine whose route is within their scope of practice. It is important to note that administering vaccines routinely carries significant administrative burden. And that concludes our 2026 Academy of Medicine of Cincinnati Pre-Hospital Clinical Practice Guidelines training. Thank you for your attention.